Hi, everybody. My name is Kathleen McFadden, and I'm a clinical ethicist and nephrologist, both at Massachusetts General Hospital and Brigham and Women's Hospital. I have been practicing ethics for quite a few years now and actually started nephrology a little bit later in my journey, but the intersection of these two fields has become both a passion and sort of the driving interest in my career. And I'm excited to talk to you a little bit today about how these two interplay and how we might think about them as we face challenging cases within our field. A little bit about myself. I grew up in the Philadelphia area, but did my medical training in Florida. And then since then, the majority of my training has been within the Mass General Brigham system. My clinical focus in nephrology really is general nephrology, in addition to my focus within the ethics space that we'll talk about a little bit more here today. I do not have any relevant financial relationships with eligible companies to disclose today. As we go through this talk, I think we'll be framing this within the context of a few objectives. Obviously, the context of ethics within nephrology is quite broad, and there would be so much that we could cover. A lot of my discussion today is going to focus specifically on dialysis and how we think about the ethical issues that surround dialysis initiation, continuation, and end-of-life care in patients who might have kidney disease. We will talk a little bit about the relevant history of dialysis care and how it came to be covered financially in the United States, recognizing that that in and of itself could be its own talk. Then we'll talk about ethical frameworks that are relevant to nephrology that might help us to navigate some of these cases through some inpatient challenging cases that I have seen. I think a little bit of a foundational understanding of dialysis really does help to frame the context of the ethical issues that we face within the field today. And when dialysis was first initiated within this country as sort of a issue that was going to need complicated financial coverage, one of the quotes that I thought was really interesting from even the initial discussions of dialysis coverage was that unsustainable trends cannot be sustained. And I think despite many years of navigating dialysis care and coverage in the United States, fear that we're sort of in a similar place even today. So we'll be talking a little bit about the history and why some of these trends have made it difficult to think about dialysis coverage. I have consistently found the initiation of dialysis care in the United States really ethically fascinating. And some of you may know, some of you may not, that a lot of the decisions about early recipients of dialysis were determined by people that were part of what were called God panels. And these were sort of conducted somewhat secretively. The members of the panels were never known, but they decided who was worthy of being placed on dialysis. And this was only revealed to the country really in an expose that came out in Life magazine, the excerpt of which you can see here. In 1960s, dialysis was allocated based on a patient's social status. And as you can imagine, that introduced significant bias into the decisions of who was placed on dialysis. Particularly on the West Coast at the Seattle Artificial Kidney Center, a team was tasked with this sort of query of who was worthy of receiving dialysis. This was a multidisciplinary team of physicians, nurses, community members, and civic leaders, and it really did perform the majority of the dialysis allocation in these cases. Social worth, as they determined it, was tied to contributions to the community and the world, such as the patient had a job where they might be providing what was considered benefit to society writ large. And in addition to that, there were sort of other factors that supposedly were taken into consideration in these cases. This obviously was inherently subjective, and there were ethical issues almost immediately identified with this practice, particularly, as you might imagine, the demographics of the patients who were deemed to have social worth were sort of foundationally ethically concerning. The NIH director at the time raised concerns that, yes, dialysis would save lives, but at a high cost to the country and to the individual, and that we needed to be thoughtful as this technology progressed from the 60s and forward to think about how we were actually going to societally manage this, both for patients and then also just for the financial implications. But as I mentioned, the expose in Life magazine sort of brought together a lot of thought leaders, a lot of nephrologists, and then a lot of people within sort of our country's leadership to think about how dialysis might be covered. I'm obviously widely oversimplifying what was sort of a complicated process, but this is just sort of how things came to national attention. In 1967, a committee on CKD met in response to this sort of expose in the growing conversation in the country about dialysis care. And at that point, it was recommended that all ESRD funding come from the federal government. And it was decided under the premise that most patients medically suitable for dialysis would be under 54 years old with few comorbidities. So just to say, the legislation that was initiated, and that in many ways still applies, was initiated with a premise that is far different than what we are actually seeing today, and really even than what happened at that time. By the early 1970s, there were escalating rates of renal failure. Congress expanded legislation at that point to provide lifelong subsidization for dialysis to all patients with end-stage renal disease. There was a significant underestimation of the cost at that point in time. There were 10,000 patients on dialysis, and then they were sort of estimating a cost of around $280 million, but this has grown exponentially since that point in time. And dialysis to this day occupies greater than 7 to 8% of the annual Medicare budget, which is an extraordinarily large amount of money in this country. And so historic questions really remain relevant today. Costs continue to rise exponentially. The annual Medicare spending is in excess of $30 billion for dialysis care. And since 2003, the number of frail elders over 80 years old initiating dialysis has been steadily increasing, which I'm sure has been most of our shared clinical experience. Mortality is extremely high for frail elders, particularly those who are institutionalized, who are over 80 and initiate dialysis. And there's a drastic decline in functional status and quality of life in particular populations of this age demographic who initiate dialysis. And so the problem, sort of just as was alluded to when all of the initial discussions started surrounding dialysis care, is that there is still a high cost to the individual and a high cost to the country. And so what becomes difficult to then ascertain is, how do we think about if we are helping people with dialysis, if the trends are sustainable, if the populations continue to age, and how do we sort of handle that internal disquiet of wanting to offer dialysis to everyone? We all sort of, I imagine, feel like the idea of those God committees makes you feel a little bit of internal disquiet, but also unsustainable trends cannot be sustained. And so how this sort of comes to a head is that within the US, at least, our medical ethics are really driven by the prevalence of patient autonomy. And so we allow patients to make the majority of medical decisions, even if we might think they're ill-advised, as long as they're not going to cause overt harm. There is this strong preference within the US that patients and their decision makers have complete autonomy in directing their medical care. And there has been a fall in trust in providers and in even patient-provider relationships since the COVID pandemic. As sort of an aside, even the number of ethics consults that we see has drastically increased after the pandemic. And I think a lot of that is driven by some of these tensions and just by overall distress amongst patients and amongst providers that have been well quantified in studies. So there's a potential crisis of dialysis care looming in the United States. The patient population is becoming more frail. We have a large number of elders living past when they used to live. We have decline in provider trust. And then we have a concern that this procedure, both cost-wise, may not be sustainable and also may not be benefiting our patients, such as we initiate them and then they see a decline in their quality of life and functional status. And are we obligated to sort of continue this at these rates? And are we going to be able to do so? And how will we navigate this? And so I don't have answers for all of this for sure, but what I do have is some frameworks for ethical practice in nephrology that may be helpful in navigating some of these difficult decisions. Frameworks are really helpful, as we know, in thinking about clinical decision-making, but also in thinking about ethical decision-making, because they help us to reduce bias. We all carry the weight of realizing that within healthcare in general, we've provided biased care sort of across the spectrum of many of our lifetimes. And these sort of standardized frameworks can help us to reduce that bias. They help us navigate really significant complexity in a standard fashion, such that we're not having a huge variation in how we approach things from case to case. And having a standard can help to reduce moral distress related to all of these things. And so the ethical principle that we use the most in the United States is this concept of ethical principlism. This came out in the 1970s in the Belmont Report and the Principles of Biomedical Ethics, which were actually established initially for thinking about safety of and ethical practice within the research space, but we really have transposed those, and now they're used as standards of care in ethical decision-making, particularly in the US. And so the 4 principles that are used are respect for persons or autonomy. And as I alluded to previously, autonomy is really the guiding principle for US medical ethics. There's far different practice in other countries, in other people of religious faith or cultural beliefs, but in the US, autonomy, sort of as the foundational principle of ethical principlism, sort of guides most practice. This does include the right to self-determination, which is within this principle of autonomy, meaning that patients have the right to determine what does and should happen to their own bodies. This then expands to their decision maker, which in Massachusetts may be someone called a healthcare proxy. In other states may be related to surrogate decision-making laws, but that respect for persons and that autonomy does extend from the patient to the person who's making decisions for them if they're incapacitated, which is often relevant to nephrology patients. The second principle is beneficence, and the third is non-maleficence, sort of the first do no harm principles and providing care that is really beneficial more than it is burdensome. And then justice or respect for persons is sort of the fourth principle that was identified in the Belmont principles. And as I mentioned, sort of patient and family autonomy are sort of central to this. With the rise of ethical principlism and this foundational sort of dependence on autonomy, what has been in decline then is this concept of paternalism. And for those who trained within the medical system or the healthcare system within really the last probably 10 to 20 years, there really has been this drive to no longer apply paternalistic practice to cases, meaning we don't tell people what to do, we seek their input, we engage in shared decision making. But at the end of the day, the sort of reflex has been that they decide, we don't decide. And there's sort of pros and cons on either side of that, but it's sort of a notable shift in a profession where in the far historic future, the practice of physicians was much more paternalistic in nature. I think something that just needs to be considered is if this has come with abdication at all, the role of physicians, meaning we do at times need to be directive, and there are certain areas of medicine where we still are. Declining surgical intervention due to high operative risk, declining certain interventions procedurally where we are not sure it would be beneficial to the patient. But there are cases where you might argue that this over-reliance on patient autonomy has sort of become so prevalent that you have to make sure that we're still upholding the role of the physicians, which is to advise, to guide people, and really to try and stop care that is not beneficial more than burdensome. We have questions we really need to think about, which is, do patients and their families get to choose all aspects of care? Is it an opt-in model, and is that going to be the sustained model for dialysis care in this coverage or in this country? And then also the benefit versus burden analysis is actually really difficult to assess. Who does quantify suffering? What you or I may think is suffering may not be what a patient or their family thinks is suffering. And what culturally or from their faith-based beliefs or from traditions in their family, what they think of as suffering may be really different than us. And I think that is challenging because we deeply want to respect those strong-held foundational beliefs that make a person who they are and sort of drive their identity. But we also do need to balance that with the fact that the care that we're providing really does need to be care that is beneficial overall. Something just very interesting as it pertains to quantification of suffering is that when studied in the AKI setting, patients with kidney disease seem to have a higher distress tolerance and a higher critical illness tolerance, but start at a lower baseline. So patients with kidney disease, when admitted to the hospital for critical illness, actually suffered, by the perception of many, a complicated hospital course, but actually didn't see the similar decline in quality of life or in sort of their perception of illness as patients without kidney disease. And I think what that sort of, if I could extrapolate, what that suggests to me is that our patients with kidney disease suffer a lot at home, and they probably are willing to take on a high degree of suffering that we might perceive as too much, but they may not perceive that way based on a functional status that is challenged at baseline by their medical illness. And a lot of that is me extrapolating, but I just find that interesting as it sort of pertains to how we think ethically about the care of these patients. If we think about how to apply principalism to a case, I thought this might be a good one to discuss together. So an 86-year-old female with advanced chronic kidney disease, hypertension, diabetes, and heart failure with reduced ejection fraction with an EF of 20%, as well as peripheral arterial disease and mild neurocognitive impairment, who had been teetering on the edge of dialysis for some time, presents to the hospital with an AKI in her very advanced CKD with refractory hyperkalemia and volume overload. She lives in a nursing home. Her family reports excellent quality of life, though she doesn't leave her wheelchair. Her baseline blood pressure is in the 90s in the setting of her cardiomyopathy, and you're worried, as the nephrologist, about dialysis tolerance. Her family is confident that she would want to live every possible day and is strongly advocating for dialysis initiation. How might we apply ethical principlism to this case? If we think about autonomy, the patient gets to decide, and her family is clear on her wishes as her surrogate representative decision makers. The patient and her family can understand the nephrologist's concern and then make an informed decision. And in shared decision making based on their autonomous wishes, they can sort of drive care for this patient. If you think about the other principles of beneficence and non-maleficence, the nephrologist has very real concerns about dialysis tolerance, cardiomyopathy, low blood pressure, functional status, living in a nursing home, and dialysis initiation would almost certainly lead to decline in functional status and quality of life. You also may ask, can the patient truly represent her interests given her dementia? And are we really upholding what is in her best interest if we're really not sure because she can't quite speak for herself and we're reliant on her family? And so you can see how, despite having this framework, the autonomous interests of the patient and the beneficence and non-maleficence that may concern the nephrologist can be at odds. And then we have to think about, often with involvement of the ethics committee or other involved parties at your institution, how do we navigate that conflict that may underlie? What do I think would likely happen in this case is that dialysis would be initiated. Conflict would be avoided. The patient-centered approach that is sort of standard really does favor autonomy as represented by the patient's decision makers in this case. The question that I spent a lot of time thinking about, but I'm not sure about the answer to, is at what cost? And is this the correct approach? Patients and their families really are important to listen to, and it's important to think about not making value judgments about quality of life in patients who are institutionalized or have dementia, et cetera. However, when we really think about the data we have on the quality of life and the functional decline and the challenges related to dialysis tolerance, I think these are really difficult questions for us to grapple with if we're actually providing beneficial care. In general, these principles of autonomy, beneficence, and non-maleficence really require iterative reapplication as cultural and societal expectations evolve for critically ill patients. I think we've seen a big shift in the years after the pandemic toward, as I mentioned earlier, less trust in providers and fewer patient and physician relationships longitudinally, even sort of with the collapse of primary care in this country. There are just fewer people who know patients' wishes and have discussed those with them. And I don't actually have the answer to this, but I think these are things we really are going to be thinking about in our field in the future. One thing I'll acknowledge, and I rely heavily on these guidelines from 2010, the Renal Physicians Association guidelines are comprehensive, and they really do provide a lot of guidance in these challenging cases where sometimes I think it's helpful to have a guideline-based supportive approach for patients when we're thinking about withholding dialysis. And they do provide guidance for patients with advanced dementia or agitation, malignancy, or other conditions with very poor prognosis or mental illness such that dialysis cannot be provided safely. I think for many people, drawing the line when we think we can't dialyze safely becomes quite helpful, but it's these more gray zone cases where we're not sure we're going to help, we're not sure we would advise it, but where the patient and their family have strong perspectives where sometimes it becomes really challenging to navigate. The next principle that I find helpful to apply when addressing some ethical challenges within nephrology is that of substituted judgment. And likely without necessarily knowing the background of this theory or exactly how it is defined, most of us apply this quite frequently when caring for patients day to day. This is an ethical framework that is helpful when a patient is incapacitated or unable to otherwise articulate their wishes. So this is a patient who is altered, who has a psychiatric illness, who has some reason, acute encephalopathy, that is they have some reason that they're not able to communicate in a standard fashion or in a way that helps us to understand what they might want for their care. This substituted judgment framework is posited to return autonomy to the patient by helping to extrapolate what their wishes may be if they could speak for themselves. So essentially what substituted judgment entails is using a patient's prior known values, preferences, and their life choices to inform a decision that was never previously queried, meaning someone who comes in with an acute illness such that they might need dialysis, but where dialysis had never been discussed with the patient in the past, and then we sort of extrapolate prior decisions to guide that. This can be really helpful in states such as Massachusetts and New York, where there are complicated surrogate decision-making laws. There's extremely wide variation state to state in the United States in terms of how incapacitated patients have decision-making authority established for them. In many states, there's a next of kin law or a surrogate decision-maker hierarchy law, whereby if a patient is incapacitated by default, typically their spouse, then their adult children, then their parents, et cetera, have decision-making authority. Some states, including the one where I practice in Massachusetts, there is no such law. And so in the case of a patient who's suddenly incapacitated, it can actually become very complicated to figure out a surrogate decision-making plan for the patient. This is actually extremely relevant as an ethical theory because up to 47% of adults require surrogate decision-making within 48 hours of acute hospitalization. There are limitations to substituted judgment. First of all, it overly prioritizes longevity, which many would argue is not always in the best interest of the patient, but often ends up being prioritized, particularly when there's uncertainty, which makes sense. If we don't know if a patient would have wanted a life-saving intervention, most will preference choosing on the side of life, if you will, in order to sort of not make a cognitive error that would have such a catastrophic impact. It may also conflict with familial or cultural beliefs because many of us have difficulty extrapolating the context of a patient's illness into their own cultural, spiritual, familial beliefs without sort of having lived or walked the walk with them before. This also can be an inherently subjective approach because, of course, someone else is making decisions for a patient who isn't really able to give any guidance. I think this is fascinating. Actually, when studied retrospectively, our best guess at what a loved one would want is often wrong. Spouses were actually quite unsuccessful at predicting their partner's preference for dialysis in various hypothetical scenarios. And so while we may think we're doing a good job with this standard, I think it's actually really helpful to realize that it has a lot of limitations and that we just are doing the best we can in a situation that is inherently quite messy and complicated. Because there really is often no alternative than asking people who may be able to weigh in about the patient's prior interest to help utilize this standard in some capacity when a patient can't speak for themselves. And so to go through a case where we might apply this principle, a 63-year-old male with schizophrenia with psychotic features, hypertensive, type 2 diabetes, who has refused insulin across his lifetime and most recently has an A1C of 11.3%, who's experiencing homelessness, presents to the emergency room with acute renal failure. He needs an urgent decision regarding RRT. And the patient's friends from his shelter are present, and they endorse certainty that the patient would never want dialysis. He had intermittently engaged with a primary care physician in the past, and there are notes document lifelong reticence for medical care and limited engagement with outpatient providers, such that he has the progressive diabetes and complications thereof. And so how might we apply substituted judgment to this case? The patient's decisions across to his life suggest that he would not want aggressive care or to engage with the system regularly. His prior practices with primary care appointments, with insulin adherence, and his stated preferences seem to suggest that a lifelong dialysis need would really not be something that he would sign himself up for if he could weigh in. A decision to recommend against dialysis in a case like this would likely be ethically permissible based on that guidance. But what I would say with a lot of caveats, we have to be really careful, obviously, when thinking about limiting a life-sustaining intervention in a patient who is not that old and who is sort of underrepresented in the system related to his mental illness. So efforts should be made to make sure that there's no one that would dissent to this. Is there a family member who knows him better, a partner, children? Is there anyone who may think that this is the wrong decision being made for the patient? It would also should be, if at all possible, discuss with longitudinal providers, meaning a call to the primary care physician and make sure that our understanding from their notes is the accurate understanding of how the patient has interacted with the system. Effort should always be made to obtain as much collateral as possible from anyone who might be engaged or know the patient at all. And then we also always have to be thinking from the ethical side about making sure there's no undue influence or secondary gain from the collateral sources, meaning the patient's friends who are presenting from the shelter. We always would hope have his best interests at heart, but we need to be sure that there's nothing to be gained by anyone else who's advising the team based on the patient's imminent demise if that were to happen. And so we can apply the standard, and we want to do it carefully and cautiously. And then we also want to do our due diligence to make sure that we're not missing any potential other factors that might drive a decision different than the one we're feeling inclined to make. So those are some strategies. There are other ethical standards and principles that we use, but these two are relatively foundational, and I think have helped me in navigating several challenging cases in the past. I guess the other thing I would say is that no matter what, I think a lot of stress and distress and burnout in nephrology is driven by the fact that we are interacting with acute life and death related illnesses all the time, if not daily, while on inpatient service. And many patients who present to the inpatient setting in extremis from kidney disease are patients who have been lost to care for various reasons, or who have fewer resources than may make care outside of the hospital easy. And so we are day to day walking through these really challenging and difficult cases, and I think it can take a toll over time. And so having these standard practices can sometimes help to make things a little bit less complicated sort of internally as we process these. So in addition to sort of applying our standard ethical principles, I think it's helpful to think through strategies for challenging inpatient dialysis cases. One that comes up quite frequently is this concept of time-limited trials of dialysis. It's really difficult to study time-limited trials because sort of how they're documented and how nebulous they are. I think that time-limited trials of dialysis feel like a really effective strategy to navigate either conflict with the patient and their family, or to buy time until a decision is made. In reality, I think many of us have seen that these really do not work that well. And I think that's because we have frequent transitions of care within our clinical team, such that a family may have rapport with one provider, but the next day, the next week, that provider is gone. And that's both for the nephrology team and then also for the inpatient team that the patient may be on as well. And I believe strongly that it's very difficult for patients and their families to withdraw an intervention once it is started. There's a lot of reticence in many cultures, but even within the United States writ large, people really struggle with this concept of withdrawing care. And so if we postpone a decision by initiating a life-saving procedure, we always have to remember that that then comes attached with it inherently a decision to withdraw that procedure down the road. And for many patients and their families, that can feel really, really burdensome. And so if I ever consider a time-limited trial of dialysis, I make it extremely clear to the patient and to their family that there may come a time when the team recommends stopping the intervention. And then actually we won't leave the decision up to them so that they have to carry the weight of stopping dialysis forever. I think that can be an effective strategy. If we ever consider a time-limited trial, it must be thoughtfully enacted with a clear exit ramp, and there has to be an established trust between the patient, the family, and their provider if we have any chance of these being effective. I think we have to be really careful to not use these simply to forego or to postpone difficult goals of care conversations, because as difficult as these conversations are, I actually think it's much more effective and in the long run beneficial for all, the patient, the family, and the providers, to have the difficult conversation up front rather than at the time of a considered cessation of therapy. And so really, really important sort of area of growth in our field, but also an area where we need more data, where we need to be really careful before we consider these. We also should be engaging with early consideration of palliative care introduction, particularly in patients in the outpatient setting who are considering conservative kidney management. It's a little bit more difficult when there's an acute kidney injury and a severe complication such that dialysis consideration needs to happen urgently. And then I think we need to really have honest discussions with patients and their families at the time of initiation of dialysis. I have come to sort of believe that honest consent really requires honest disclosure. And so a patient with end-stage liver disease who is not being listed for liver transplant, their mortality is exceptionally high. This has been very well studied and very well described. And so if the patient has a close to 0% chance of leaving the hospital in good condition and off dialysis, I think we do need to be honest about these data that we have in special patient populations, such as those who have sort of had a bone marrow transplant, that hospitalization, patients with advanced malignancy, patients with end-stage liver disease, areas where we have good data to describe what the course and the prognosis will be like on dialysis. I think we need to be very upfront in the consent process about this. And if we're considering initiating in these patients who have extremely poor prognosis, it is very important for their families to know that we are likely only delaying death by a period of time, but we are actually not preventing it. And we need to be open about the fact that our procedure is one that is cumbersome and maybe burdensome. And if they opt in and if the team feels strongly about initiating, it's certainly, worth discussing. But if we are going to provide ethical consents for nephrology-based care, I think that does include a glimpse into the prognosis once dialysis is initiated. And then there are various shared decision-making frameworks that can be helpful. I won't go deep into those, but just for reference, that can help us as we engage in these really complicated and really difficult decisions with patients and their families at the time of dialysis initiation. I think in addition, we really need to think about mitigating distress within our practice. So nephrologists are increasingly being asked to navigate conflict and complexity. And we've all been in cases where a patient is in multi-pressor shock and intubated and sedated and has received chemotherapy or has had a complicated organ transplant. And then people sort of hope that nephrology might say no to initiating dialysis. And then we sort of feel this tension of worrying dialysis won't help, but not being sort of put in the position of being the person to decide when someone sort of has reached a point where we don't any longer think that ongoing critical care will help them. And there sort of is this place that we find ourselves in frequently within our profession where we are navigating extremely complicated and conflicted situations. Patient and family distrust, as I alluded to, does feel like it is rising, and that is balanced with our professional expertise where we have seen these cases play out. We have good understanding of the data for our patients, and I think we worry a bit about how much we're helping patients and their families with our care. We also have reached this critical precipice, I think, in our country where it sometimes feels like there's no limit to what people deem as acceptable suffering. And it's challenging to witness sometimes, it's challenging to manage, and it's challenging to provide care where many of us feel like we're propagating suffering as opposed to helping facilitate care. And I recognize we're talking about the extremes of cases. There are so many people that we help day to day with nephrology-based care, with ICU nephrology, with CVVH, of course. But there is this sort of tenor of more and more cases over time that we face are starting to feel challenging as the population ages. And when I'm thinking about that specific population, I'll just acknowledge that many of us find this a bit difficult to navigate, and it over a career can really drive sort of distress and dissatisfaction. And there have been well-described worries about the sustainability within our profession, among burnout amongst trainees and amongst those who have been practicing for a long time. And so I think we as a cohort really need to think about what can be sustainably done in a field where we continue to have a lot of challenge related to dialysis initiation and sustaining dialysis both in and outside of the hospital. And things like divisional support and then hospital policy and national leadership, I think, are really necessary while also providing peer support. And I think in terms of hospital policy, for example, there is sort of a drive towards having institutional standards by which we sort of think about what level of care is appropriate to offer and to provide within the hospital. But dialysis and dialysis initiation is so nuanced, and the factors that play into the safety of dialysis are complicated that I think it's very hard actually to protocolize and standardize. But just to say that sometimes having the national, like RPA guidelines, for example, having an institutional structure and then also support from one's own division can kind of help so that an individual clinician at the bedside doesn't always feel like they're at the center of these really difficult decisions about dialysis initiation, and all these things can help to mitigate distress. And finally, I think that case-based discussions actually at grand rounds or at institutional team meetings can actually be really helpful in sort of disseminating the distress. Rather than one nephrologist facing a really tough case alone, it can actually be quite helpful to have divisional sort of buy-in and collaboration. And we often engage in that here in cases that are quite complicated. So take-home messages, I would say that ethical challenges are rising in nephrology as patients age, as cases become more and more challenging. And this is a difficult time where there is a significant amount of distress, both in nephrology, but I think in medicine writ large, as we've sort of progressed past the pandemic. It has been just a challenging few years to practice medicine. Nephrologists can use substituted judgment and principlism to support ethical decision-making, and certainly can always reach out to institutional ethics-based support. And I really believe that a strong take-home should be that we need to be really cautious with time-limited trials of dialysis and how we think about ethical decision-making in these types of cases. And just to reiterate again, that national and institutional standards are necessary to guide decision-making on dialysis provision. And to sort of come back to where we started this discussion, if we think about this concept of unsustainable trends not being sustained, as we think about the cost of dialysis care, certainly the cost of something should not drive whether or not we offer dialysis to a patient. But I think nationally, we must come to terms with the fact that we are spending exorbitant amounts on dialysis for patients who were never in the initial phases thought to even ever become candidates for dialysis. And certainly we don't want to make recommendations based on age, based on financial situation, but we also really do need to think about how do we balance this benefit versus burdensome care analysis in dialysis patients. And I think that's going to be something that's discussed in our field for years to come. Thank you so much for watching this talk. I'm happy to be contacted anytime to discuss any ethical issues in nephrology further. Hope you found this helpful today, and my references are here.